So looking at post-op colorectal surgery, and we're talking about Mr. Jones, who was a gentleman who had the surgery because of a cancer. OT role will vary quite a bit during his actual stay. So we'd like to get to meet the client as soon as possible, normally 2 or 3 days post-op, just to start the conversation, get an idea of where they're going back home to, what sort of supports they have, also where they're at psychologically as well, and start to look at different techniques that can make life a bit easier. So I use the example of the electric bed that's sitting behind me here. Most people don't have one of these at home, so to go from lying to sitting when you've had any abdominal surgery can actually be quite painful. It's great when you're in hospital, you press a little button and you sit up perfectly and off you go, and then suddenly you're faced with a completely flat bed when you go home. So just starting to get into the habit of rolling on your side, maybe using your arms to push up and things like that. The sooner we can start that, the better for the client as well. Start to get them out and about a bit more, and we work very closely with both nursing and physio in that particular element. The OTs are often, and especially if you're finding that you're on a ward that's under-resourced, we'll see a client quite close to discharge and normally pull them quickly to give out some equipment to get them back home. And if we look at discharge planning around the client, it's not as simple as just looking at a piece of equipment. It really is about what environment they're going into, how they're managing. I have had clients who are managing very well from a physical point of view, but emotionally really can't even look at the stoma. Also looking at how it interacts with their other roles at home, such as being a husband or a wife. I had one little lady who was blind and used to swim, and she was quite upset now that she had the stoma, and in fact managed with the stomal nurse to learn how to change it with being completely blind, and became an excellent person to come and actually train other clients. So it really does depend on what we're looking at. Normally it's a very quick assessment when we're looking at trying to get somebody home quickly if it's at the last minute, but we haven't forgotten to not just look at the physical aspects, the cognitive and the affective as well. Sometimes post-surgery people do get a little bit of a post-op delirium, and you might come across as being quite normal. Again, if someone does an MMSE or you have a conversation with them, they're alert and orientated, but the moment you start to delve in a bit more, where there's a bit more problem solving in that, which affects the way that you take your medication at home, the way you prepare meals, perhaps the way that you get out and about in the community, likely that you're not going to be driving 6 weeks post-op, so how are you actually going to manage to plan your bus route to get to the shops? You're not allowed to do any heavy lifting, how are you going to manage your shopping? Things like that that we'd start to look at.